Would you like to perhaps go along this way, and if you could say who you are and where you're working and what you're doing?
Yes, thank you. I'm Elaine, and I'm the Director of Operations for the National Joint Registry, which is based at the Healthcare Quality Improvement Partnership, who host us.
Right.
I'm Matthew Porteous. I'm a consultant orthopaedic surgeon in Bury St Edmunds, and I've been working with the National Joint Registry since very soon after it started. I chair 2 of their committees and sit on just about every other committee there is. So I have a fairly good knowledge of it from a clinical side.
Lovely, thank you very much.
I'm Laurel Powers-Freeling. I'm the chair of the National Joint Registry Steering Committee, and I'm a volunteer, but I have been the chair now for 7 years.
Right, thank you very much.
I'm Nicola Miller, and I'm Head of Registration for the National Congenital, Anomaly and Rare Disease Registration Service. I'm Head of Registration for the North of England.
Thank you.
Hello, I'm Sarah Stevens. I'm a public health consultant, and I lead the National Congenital, Anomaly and Rare Disease Registration Service, hosted by Public Health England.
Right, okay, thank you. That's really helpful. One of the things that we've been considering, not only this morning when we had another group in, but we've been thinking about it quite a lot in our own discussions and testing it out on people. And one of the things that we think is really important is to actually, when we're talking about registries, talking about databases, what do we mean by them? Because there seems to be a bit of confusion in these terms. So if I could just read to you the definitions that we've picked up, and if you could tell us if you think this is about right, we'd be very grateful. Or if you say, look, actually you need to improve it, etc. And it's quite a lot to take in one go, so we can easily send it to you and you could make your comments later on. But for the purposes of this afternoon, we're talking about a registry as an organised system that continuously and consistently collects relevant data in conjunction with routine clinical care, evaluates meaningful outcomes, and comprehensively covers the population defined by exposure to a particular medical device or devices. At a reasonably generalised scale, for example, international, national, regional health system, with a primary aim to improve the quality of patient care. Now, that's taken from International Medical Device Regulations Forum. So that's where we've gone to for this definition. Do you think that pretty well covers it for a registry? Okay. So the database we're talking. Sorry.
I suppose one of the questions in there is whether the data sets are comparable. So are you simply registering an incident or registering a procedure or a case, or are you trying to register something which you'll look across for comparative and analytical purposes?
Well, I'd like to go on to the database now, because that definition is what we think would be the first step, as it were, to get a proper database, and then arising out of that would be a registry, which would obviously would be more fulsome and would include a lot more patient information. So if I could just say the database, and this is the Oxford Dictionary, a structured set of data held in a computer, especially one that is accessible in various ways. For our purposes, this is the review talking now, for our purposes in relation to MES, such a database might include the NHS number, type of procedure, operating surgeon, healthcare provider, unique devices identifier, date of procedure, age of patients, gender, and gender. So that's how we would see a database. Does that sound about right? Okay. Cyril, was that my fault?
It was, I switched it on.
I'm so sorry. Right.
I think Laurel would like to.
Yes, okay.
At the risk of jumping ahead of something else, I suppose the nature of the device I think in total we have about 5,000 different items on the NJR database. And so there's not a hip replacement. There are a wide range of options involved, and that can be due to the metal that's being used. It can be something about the way the joint is constructed, etc., etc. So within the device definition, the specification of that is actually critical to understanding which ones.
We do understand that.
Okay. Just want to make sure.
And you do run a very good joint registry, which is why we're here to hear from all of you. But what we're trying to do is to understand how you identify patients, and you do that with security that you're right, not secondary through HES or something like that.
Mm-hmm.
And so we want to separate, just for the sake of conversation, so we understand what we're talking about, the registry, which is a detailed piece of information looking at long-term outcomes and all the complexity that is. My personal experience is that I was on the European Dialysis and Transplant Association registry for many years, looking at children with end-stage renal failure across Europe. So, and constantly interrogating the registry, asking questions, going back. But you've got to be sure you've got the patients right to begin with. And so what we are suggesting is that we think through NHS Digital, identifying the patients. There are questions then about GDPR, which we're going to come to during the next hour. But the notion is that a surgeon, if I may as a paediatrician put it this way, but when she or he carries out an operation, they fill in the operation note, that note contains the core information which we've just been through to identify the patient, the doctor, the procedure, which is then probably mandated not only to the hospital notes but to a central register, a central database, now I'm doing it, central database, which the register can then interrogate in the more complex ways that they do that. And we have to be thinking about all the different registers that exist and need to exist, and our particular issue is in relation to surgical mesh, where we don't have it, and we need urgently to have it. It's part of the reason we asked for a pause in operations until we got it. So it's a question of how you set that up. Now, as I understand it, again, we're going to be asking you this question. Under GDPR, you can indeed mandate under Section 251 the collection of information for a legitimate purpose. But what is also clear is that if you run a register under the opt-out, you can opt out from being on the register. Whether that relates to GDPR or the common law due to confidentiality, I'm going to ask you to advise me about that, because I don't completely understand it. But that is the reason we've separated the two, and we put to the President of the Royal College of Surgeons and to the President of the Royal College of Obstetricians and Gynecologists whether they would, in theory, support a practice whereby this core information is included in the operation note, which will then serve as a database which can then be linked to proper registries. That is the background to this way of defining it. Does that make sense?
All right. Yes. Good. Thank you very much. So if I could first start off then to ask you, could you describe what you consider to be the strengths of your own registry and how it could be improved?
Okay, so we're the biggest registry of its kind in the world. We've got 2.5 million records, so we have mass, size of that sort of size has a beauty all of its own, because you can really start digging down into the data. We had about 250,000 records a year now. We've got 95% compliance, which is gradually crept up. It was dramatically improved when in 2011 entry was mandated. Before that it was voluntary. And if you're going to have a registry and you don't mandate it, you might as well not bother, in my view. Then we have a data quality audit where we go back and check what's been entered against what's been put into HES. We've been running that for the last 4 years, so we're now very near 100% compliance. Retrospectively, we do that retrospectively about a year in arrears, to make sure that we've got a good data set. We have really good now, in the last few years, we've really developed, we've gone from being a registry that is looking particularly at devices and whether or not brand X is a good brand or not, to a registry that actually supports good clinical practice. And that's been the dramatic change we've had, so that every consultant who puts in a joint replacement gets access to their portal. They can look and see what they've been doing, they can look and look at their performance. And now there is a consultant's clinical report once a year that is downloaded. My report, for example, runs to 32 pages of detailed information about my personal performance. That we're also pushing for that to be mandated as part of appraisal. Now, all the good people use it, but we know that actually about a quarter of surgeons don't download it and use it as part of their appraisal. But we're getting there slowly. We have 2 years ago we undertook a transparency and accountability agenda, so exactly how we do everything has been laid out, and that's all available on our website, so that particularly for alert and alarm surgeons, hospitals, implants, all of that is laid out clearly so that people know how it works. And we spent a huge amount of time laying out spreadsheets and charts and accountabilities and responsibilities for that, and standard operational procedures for the whole of all of those things. So I think those are the main things from my point of view.
Well, thank you very much indeed. Can I ask then, you're saying that surgeons will look at their performance. Can they look at other surgeons' performance?
You can't see other surgeons' outcomes. You can see their patient demographics. Those are published online by the NHS, and so you can look at those for any surgeon. You can look up a surgeon, but you can't see what their outcomes are. What we do for individual units is we send a unit report which has individual surgeons marked. Those surgeons are anonymised in theory, but you can always, in my unit, I know who they all are because you can work out roughly how long they've been there and what the dots are. And we very much encourage, just both us and the GIRFT initiative, encourage every unit to sit down every year and go through their unit report, and for each surgeon to discuss
Can you
their
just
personal
get it right first time?
Get it right
for the
first,
audience.
Sorry, Get It Right First Time initiative, which started in orthopaedics.
But there's no sort of benchmarking of individual performance against.
There is a bench, very much so. You get a funnel plot. Each individual gets a funnel plot, and they can see where they are on that funnel plot, and where everybody else is. But I mean, everyone else, there's so many surgeons, it's just a mass of dots. We identify outliers. And I'm part of the Surgical Performance Committee where we identify surgeons who are outlying, and there is a whole process for managing surgeons who reach alert and alarm level, but that is all done confidentially. So even in the committee we don't know who the surgeons are. It's only when they break the code that surgeon 7692 is the surgeon who has been outlying, then they get sent a letter. Does anyone know who they actually are?
Essentially the funnel plot enables an individual surgeon to say, okay, I'm here.
Yes.
Plot. These are all my contemporaries.
Yes.
So there is a sort of comparator in there, but it's
absolutely.
a normal.
And you can see where you are in relation to the mean, and whether your performance is better or worse than the mean. But we're very conscious of the fact that we don't want people ranked. To become an outlier at alert level, you have to be 2 standard deviations worse than the mean, and to become an outlier at alarm level, you have to be 3 standard deviations worse than the mean. That's 1 in 1,000 chance that is a statistical aberration that you're there.
So the outliers know who they are.
They do, and there's a whole process for managing those once they've been identified.
Could you tell us a bit about that?
We write to them, this is for individual outliers, we write to them individually and tell them that they're an outlier. almost without exception, they have actually had a letter when you reach alert level, which is 2-step. You get a letter that all we ask for is an acknowledgement to say, watch it, you're heading in the wrong direction. Basically, we don't require any action to be taken. But if you reach alarm level, then we send them a letter, and 6 weeks later, we send a letter to the medical director of the hospital, informing them they have an outlier there, and we require them to send us back an action plan. We give them an outline of what it is we want them to do and how they, and we want to know why they think they're an outlier, and we want them to tell us what they're going to do about it. We then review that answer. Very occasionally it's not very satisfactory, and we send it back again and say, no, you've missed the point here. In the very rare occasions where we've had major problems, we then go to the CQC, who sit on our surgical performance committee, not because they can do anything about individuals, but because we recognise that there may be a failure of governance mechanism within that organisation, which they will pick up on. Assuming everything's done according to the book, which happens 99 times out of 100, then we then actively monitor that surgeon to make sure that their change in performance occurs as they have promised us.
Do you want to say anything about unit interventions and the visits?
We have, yes, we have more recently tightened up unit outliers. We've had outliers outlying units have been outlined for years and have never done anything about it. And the British Orthopaedic Association have now set up a thing called an elective care review, where a hospital who is having problems can invite a team from an independent team, nothing to do with us, from the BOA, to go into that hospital and advise them as to what they need to do to improve.
But we provide the information.
And we provide information. We provide the information to support that, and we have recently recommended a number of hospitals who have been persistently outlying and have never really sorted themselves out to have elective care reviews, and those have, some of them take place and some of them are about to take place. Where the hospital has been resistant to that, the CQC have become involved and have told them that they need to have one.
I think the strength of the system that we now operate, looking at outliers for units and surgeons, arose from the accountability and transparency modelling that we did. So that now we're working with the specialist societies and the BOA, the regulators for implants, MHRA, but for surgeons, CQC, and this didn't happen before. So it's a really joined up plan that I think is worth mentioning.
Can I ask two questions then? The first one is, do some of these outliers appear an outlier a year later when you're doing the process again?
That's the answer is yes, but the reason for that is because of the way we calculate outliers. We use a thing called PTIR, patient time incidence, and that means that there's a huge drag on the system, so that it's quite difficult to become an outlier, but once you become one, your previous activity means that you're likely to remain an outlier for some time. What we like to see is a trend, talk back down in the right direction. And what you have to recognise with joint replacement is that it's a very slow game. So you can put a joint replacement in and it might fail in the first year, and we all get a few failures in the first year, but not very many. And then if you start to have failures at sort of 6 and 7 and 8 years, that's probably because there's something you've done or you've selected a bad joint replacement. Really good joint replacements will last maybe 20, 25 years. So this isn't something where you put it in and snap, you're immediately an outlier. It may take some time for you to become an outlier.
But in the meantime, those patients could be harmed.
Well, absolutely. I mean, I would accept that, but what we don't know is, even now, we don't know what a really good joint replacement looks like. And something new comes onto the market. There is a system now in orthopaedics called Beyond Compliance, where those are much more closely monitored than joint replacements that have been around for a long time. But because it takes a long time for joint replacements to fail, the best example we've had recently is metal on metal with the ASR hip. It was perhaps 7 years before we identified that there was a serious problem with that hip. And that wasn't helped by the fact that some hospitals putting them in were poor to comply. We're going back to the beginning of the NJR now. I think we'd pick that up a bit faster now, but you're not going to identify a bad hip replacement really, really fast.
It's worth mentioning that the metal on metal hip It wasn't that surgeons made a bad decision, so it's not about the capability of the surgeon. It was in fact recommended as a good prosthesis, but it took 7 years to recognize that the wear on the hip was actually problematic, and so it is as much to pay attention to the implants themselves as it is to the surgeons that we operate the registry.
7 years is a long time.
Yeah.
And there's
A lot of patients would have suffered through that.
it is unfortunate, and it is a function of something that is intended.
Can you
to
not
last
speed up your
15 to
system?
25 years. Well,
Sorry, I didn't hear.
Can you speed up your system?
We can speed it up if we improve compliance. We've done that now.
Yep.
So compliance at the time the ASR was happening was not. So our numbers weren't big enough because it's a statistical game you're playing, really.
Yes.
I think you have to recognise that all implants will fail. You know, hip replacement is great if it sees you out, but if you put them into people in their 30s and 40s, they're all probably going to need revision, and they get told that at the time they have their hip replacement. And then it's a question of, is brand A better than brand B? So it's not a question of that this is a really bad hip replacement. There are huge shades of grey in there. We don't always know which the very best hip replacements are for different groups as well. So an 80-year-old having a hip replacement might need a different hip replacement because longevity is not that important if you're 80, because you're very unlikely to live 20 years statistically. Whereas if you're 40 or 30, then that hip replacement might have to do 40 or 50 years. And that might be a different hip replacement, which is a bit more expensive, or it might not be, and we don't even know the answer to that yet.
Some advice then on surgical mesh. What should we be doing about that? Because that involves surgeons.
It does. I was interested to hear the thing you said right at the beginning about the difference between a database and a registry, and we took the view in the NJR when it was set up that we don't try and interrogate records because that's too difficult. We require people to fill in a form, and that goes into our data, and it's completely separate from the patient record. In an ideal world, you could try and link the notes to the record and gather the data that way. I think you'll have a problem doing that because I don't think the systems are well developed enough in hospitals to pull all that information out.
We want to mandate, and that seems to be the right word to use, and you more or less said that every operation that involves a device at any rate, the surgeon, when they fill in the operation note, that record is then completed, goes to a central database, so at least you've captured it. Then we can talk about how you establish registers after that. But before you go on, could I just ask you, do you cover the private hospitals as well?
No. The NJR we do.
Yes.
I don't run private work, but we don't.
The NJR does.
Yes,
The NJR covers the private sector as well, and it is mandated. In fact, it was mandated in the private sector before the NHS.
From the outset,
Good.
strangely.
Oh, well, that's interesting. Yes.
So in 2003, independent sector was mandated, but not the NHS, and as Matthew has said, that came
Very
in
good.
2011.
Thank you. Sorry, I interrupted.
Oh, no, it's quite all right. I'm sorry.
Can I just ask Sarah and Nicola, in terms of NCARDRS, if that's an acceptable acronym to use rather than the full name?
Yeah.
What do you think are the lessons to learn from the work that you've done in the registry that you've accomplished in terms of thinking specifically about what we've got to do, think about, which is surgical mesh in this context, but your strengths, the strengths of what you've done and the lessons you would be able to impart to us would be really helpful.
So I think we've got four key strengths. One is definitely population coverage. So we started congenital anomaly registration in PHE in 2015, so we're in our fourth year. At that time, there were regional registers covering parts of the population, but half of all births weren't covered at all, so there was no coverage in London, in the southeast, in the east of England and the northwest. So in the last 4 years, we've moved these regional registers into PHE and then expanded to cover the whole population. And I do think where you're looking at rarer conditions, obviously having that population coverage is a real strength. We are one of the biggest in Europe now. The other thing is that what we've done over the last few years is build a single national data management system, so that cases are registered in exactly the same way, whether they're in Newcastle or in Bristol. We have standard operating procedures, they're coded and classified in the same way, with clinical expertise putting into that.
Sorry to interrupt, have you developed those yourselves?
Yeah, we've used, there's some international standards. The EuroCat is the European Registry's surveillance programme, and we've used those, and what was happening before in the regional registers, but we've developed those as a standard nationally. Yeah. And I think that has been really, really important to do. The other thing is actually, it's interesting the conversation about mandated data sets. We're not a mandated data set. It's something that we would good to explore. So we do rely on the goodwill of clinicians sending through this data. So another strength of ours is taking a multi-source approach. We get partial information from different places, from antenatal detection, so from a pregnant lady coming in through screening, and we'll follow that all postnatally too. As you all know, the information is fragmented, it's all got its limitations, so actually taking this multi-source approach and piecing that information together with key identifiers is the reason why we can increase our case ascertainment and coverage. So that's been a real strength for us as well.
Do you collect information on maternal illnesses as well? So do you collect information on epilepsy and pregnancy and medications?
We do, yeah.
We do, yes. But we're probably better at that in the antenatal period. So if an anomaly is detected antenatally, we would be notified of that case, and we would also be notified of maternal illnesses, etc. Where an anomaly hasn't been detected in the antenatal period, the anomaly would often be reported to us by paediatricians who wouldn't necessarily be holding maternal data at the same time, so we would need to go back and interrogate that for that case.
And how long do you follow the child through?
Our aim is to follow the whole life course. I think at the moment we definitely up to a year. Some regions have been going a bit longer than that, haven't they?
We would follow through in terms of new diagnoses on the same patient, so that would come in and would be added to the case.
Okay, so you have a lifelong track for anyone that's on your interest.
Yeah.
Do you contact the families directly?
No, only through the clinicians. Yeah.
Does that, is there a disadvantage to not contacting the families and getting direct reports of experience?
So we don't get any self-reports at the moment. That is something we're looking at doing through rare disease work, actually, enabling patients to self-report. But for congenital anomalies at the moment, no, it's only through clinicians reporting, or what another strength I think that we've achieved is actually getting electronic feeds directly from cytogenetic labs, from biochemistry labs, and using the routine data sources that are available, because obviously that reduces the burden on clinical time. So we've moved to electronic reporting entirely, and we give notifiers a number of different ways that they can report securely to us. So we take the data in whatever form they are able to give it to us. We do have electronic notification forms, but we'll take information if we're copied into an email for a referral, anything that we can do to keep the burden on clinical time as low as possible.
Do you collect transgenerational follow-up data or not?
That's an interesting question. The way that we've set up the data management system, we will be able to in the future. I don't think we've done that as regional anomaly registers particularly well, although you can see links in the old legacy databases, but the way the new system is set up, you will be able to see links between women who have female children and then those children having.
You are obliged to give people the right to opt out.
Yeah.
2 questions. Has anybody done that? Yeah.
Yes, we've had less than 5 in the last 4 years.
What proportion is that?
Less than 5 patients of
Yes, so it must be
contact.
a tiny
Yeah.
percentage.
Yeah, very small.
But that must mean that you can contact the families. You know how to do that.
So because we take this multi-source approach, we do take identifiers, both of the mother and of the baby, and sometimes of the family. So we would have their address, date of birth, NHS number, and normally the core ones.
So you could actually contact the families and get information from them if you wish to do that.
We could. The reason why we use the clinicians is to ensure that the information that we have is up to date.
Yes.
So it's another validation, I suppose. Yeah, we could. The last point I was going to say about the strength, which sounds very similar to the joint registry, is actually about getting the data back as well to clinical teams and the importance of doing that. And that's something that we've really worked on, and to patients and the public as well. Really, we don't want this information to be going into a black, box. It's about getting it back out in a timely way and using it to inform provision of care. Particularly for us, it's antenatal screening. So every trust that provides maternity care, so it's 136 in England, they now will get a tailored report on their antenatal detection rates, on their prevalence, and that's been a new thing that's happened in the last couple of years.
Do you provide an advice service for patients and families? Can they contact you?
Yeah, all our information is available on the website. We do get patients contacting us, and we work really closely with the patient charities and groups as well. So we would do a lot of signposting to those groups.
The input's not mandated, so do you know how comprehensive your database is? Do you have any idea?
It's estimated that around 2% of all births in Europe are affected by a congenital anomaly. That's the findings from research that Eurocats has, which has been going since the early 70s. And we know we're hitting that for those areas where we've got well-established regions. So that's why we think our case ascertainment is good. In the regions where we have just set up, so it's new feeds coming through, we're tracking those at the moment when we know there are gaps. So we're working on improving the quality of the data there.
I do understand that what you're doing is extremely sensitive, and you have to be very careful how you go about what you're doing. But if there was an opportunity to contact parents, mothers, as Cyril has suggested, do you not think there's a huge advantage in that? Because we've met women who have had 5 deformed babies. Now, if perhaps you had been able to contact them, then that might have prevented 3 of them being born disabled.
I think there's an advantage to being very well known and allowing parents and families to contact us. I think the downside to directly contacting patients is that obviously these are very sensitive situations, and we need to be absolutely sure what situation that family is in before we make contact with them. Obviously it's very sensitive to be contacted by a service like ours immediately after being bereaved, for example. So I think that's why we tend to do any such contact using clinicians, using less known clinicians to come and make those kind of connections.
Could you tell us a little bit about how you're funded?
Go on.
No, I'll
Elaine.
just kick off. But it's subscription. It
We
used
have
to be
2 forms of funding.
Yes,
Yes,
exactly.
so
There's
we
trust
separate those
subscription, and there's a levy subscription from suppliers, and that wasn't always the case. It was just through trusts. So this is a much fairer system, and we calculate the subscription for every trust based on the number of components that they've actually used that are logged with us, and procedures that they've done. So there's a calculation to be made on that. And similarly for suppliers, it depends on their size as to the charges that are made. And I think where it works out fairly is that the information that you can actually provide back to trusts and to suppliers, I think is key if you're asking them to pay and financially contribute towards the registry. So units get their management feedback, their surgeons, as Matthew's described, they get their annual clinical reports, consultant level reports, and suppliers have a system we call supplier feedback, and they can go into the system and they too, which I think is very important for a device registry, can actually monitor the performance of their devices. And in actual fact, it's quite unique in the world, so that the manufacturers operate internationally, pretty much the same manufacturers everywhere, and they actually use NJR supplier feedback for regulation in other countries when introducing their devices. So they kind of get a bit of payback as well, but it works very well in terms of funding.
What kind of limitations do you put on suppliers' access to data, if any?
They can only see their own data, so we don't allow them to see other manufacturers' data, which would obviously it would be commercially inappropriate to do that. So
Can they see data about surgeons' performance and outcomes?
No.
No, but they can work out sometimes. I mean, if you're only supplying an implant to four units and there's a problem in one unit, you can probably, if you're there, you work out who it is.
So they can see the outlier profile, can they? Or
No, but they'll know if there's a very limited number of people using something and it'll be, and somebody's an outlier, that implant will be creeping towards becoming an outlier itself. We've had one instance of that.
Can they see against the class product? So could they compare their individual product against the class generally?
They can compare it, I believe, against, I mean, in hip replacement we have cemented and cementless, so we divide up.
Yeah.
And we're having a big debate about the moment about whether that's appropriate, whether actually hip replacement is a hip replacement. If you're a patient, you don't really care what it's, you just want it to last a long time. So that data is published anyway. We publish that in our annual report. So for the high volume implants, then there is detailed breakdown of those in the annual report every year.
So a manufacturer in effect can say, okay, this is my product within this class and my product outperforms the rest of the class or underperforms.
Yeah, and they do that and they use it in their advertising.
Yes.
You, in the very helpful slides you sent us, I see that you're accountable, well, I think you're accountable, or you're related to NHS England.
Yes.
Yeah.
What is your relationship with NHS?
The history was that we were set up after the metal disaster, after the capital hip disaster, by act of Parliament, and the idea was that we were independent, but that we would have a relationship with NHSE. So once a year, I go see the medical director of NHSE and talk about the progress that we've made, the changes, what we need from them, how we think that we can develop the National Joint Registry to better serve.
So why aren't you part of HQIP?
Well, we are hosted by HQIP.
Ah, you are?
Yeah,
All right,
we're hosted, but we're not part of NCARDRS. We're not part.
But nobody seems to be part of HQIP. They're just a host, aren't they?
We think of them as a supplier, I suppose, is the best way to look at it. We have three main suppliers. One is Northgate Information Systems, and they basically hold all our data and manage our IT infrastructure.
Do you have any bad debts?
Sorry?
Do you have any bad debts?
None.
So the hospitals pay out regularly, do
Yes, we are solvent. In fact, we have reserves.
Well, I didn't mean to suggest you weren't. But I don't quite understand why NHS England just don't cover your costs on a some sort of basis. Why you have to build?
It's a historical point.
We are unique because central funding comes down for all the other audits that HQIP actually commission and manage.
Yes.
As Laurel said, we're actually just hosted by them because we're not a legal entity. So we have to have an umbrella organisation to probably contract and be our data controller, and that's the relationship. And historically, as Laurel said, from day one, we have funded via a levy.
Now you hold patient identifiable data.
Yes.
Therefore, you fall under the general legal requirement of the duty of confidentiality, common law duty of confidentiality, and GDPR, right?
Absolutely.
Yes.
So that means that, as I understand it, patients have a right to opt out.
Yes.
And so, how do you deal with that? Do you write to them? Or?
No, we basically, what we like to happen is that every patient is formally consented as part of the consent process for surgery for data entry into the National Joint Registry, and there is a consent form. My practice personally is to do that at the same time as I take the consent for surgery. There's two forms, there's the NJR consent and there's the consent for surgery. I have to say I have never had anybody who has opted out. I've had one or two who've expressed reservations, but when you sit down and spend 5 minutes explaining what it is, that they won't be contacted, that the data is confidential.
However, as an organisation, you have the need to actually demonstrate that you're compliant. How do you do that?
We have, well, the first thing is that one of the things that has to be entered is whether or not consent has been obtained from the patient, and there's a yes, no, and I don't know box.
Okay.
The good organisations will be 99.9% yes, very occasionally a no, and very occasionally a don't know. We do have a, I don't know what the right word is, not having been consented is regarded as yes, and we have a special dispensation for that. So the only people who are no are the people who have actually said no.
Because they've opted out.
Because they've opted out. That is,
very small.
It's tiny. It's tiny.
We also link to HES data, so we have a cross check on whether there's anything on HES that for one reason or another we haven't picked up, and we can follow back.
And how often does that arise?
How
often does that arise?
We've had all sorts of problems with HES, as you probably know. There have been lots of issues, and we had about 4 years in the wilderness where we weren't allowed to access HES data, so we just got on and did our own thing. What we've actually done for our data audit is we have linked to individual hospitals' PAS. We've asked them to send us a download of their PAS records, which are one closer to the hospital than HES, hasn't been cleaned up in quite the same way. And then we compare the hospital's PAS for that period against what's been entered into the NJR. And you've got three outcomes: it's on PAS, it's in the NJR, or it's in the NJR and it's not on PAS, which means that there's a coding issue for the hospital, and we've had some hospitals that have lost hundreds of thousands of pounds through poor coding. We've identified too late for them to retrieve that. But they've tightened up subsequently, so it's useful for them to know. Or it's on PAS and it's not in the NJR, in which case we say, well, please check and see if this should have been in the NJR, and then enter it retrospectively.
However, now you are working closely then with the NHS Digital. You share information.
Well, we get the HES. We get the HES.
We do get the HES.
Do you have a similar close working relationship with MHRA?
Yes.
Oh, yes.
Much closer.
Can you explain how that works, please?
The MRHA sit on our implant scrutiny group.
And our steering committee.
I'm on the steering committee. And so the implant steering group review the data on implants in the same way as the Surgical Performance Committee review the data on surgeons and trusts. And we identify outlying implants or implants that are giving us cause for concern. They're discussed. We sometimes commission more detailed work.
So if I, as a patient, have got a painful hip, and I think my hip replacement's the reason, and I fill out a yellow card, how would that get back to you?
It wouldn't. I think it would be fair to say. I mean, I haven't ever come across a patient filling out a yellow card. Yellow cards are an alert device for medicines, but I didn't know it.
It's also for medical devices too.
Okay, well, there you go. The ignorance about orthopaedic surgeons on this. But what does happen is that if there's a concern about an implant, which doesn't usually come from a patient, it normally comes from a surgeon, then they do
our problem
discuss that.
Is that in mesh,
yes,
it is a sad fact, it's come from the patients.
Right.
Right.
Okay.
So that's why we're so concerned.
I can see that. Well, we fairly regularly, I don't chair the implant scrutiny group, but I sit on it. And the chairman fairly regularly gets a communication from a surgeon saying, where I'm a little bit concerned about this combination or this hip or this knee, and when that happens he always brings it to the committee, and usually by the time he gets to the committee he's actually done a dive into the data and had a good look at it to see whether or not this implant, there's any suggestion in the registry that the implant is giving cause for concern.
I'm trying to ask you a question without leading you to the answer, but I have an artificial heart valve.
Yep.
Do you think I am as safe as I would be if I had an artificial hip in terms of outcomes as spotting goes wrong?
Well, the thing about an artificial heart valve is that when it fails, you're dead. No, but I mean seriously. So that's a very definite end point.
But I promise you.
Whereas a hip replacement doesn't fail like that.
But I promise you it fails slowly.
Okay.
All right.
Can I just step in, Matthew? Because I think I would say to you it's probably 6 2/3 because I think I'm right in saying that you have a registry. Cardiology has a registry that is okay.
They do for stents and things like that.
So that's why I asked you the question.
Yeah.
I mean, basically, I haven't said about it, but it does seem to me that I'm much safer if I had an artificial hip because
Well, I didn't know that. I assumed it was registry. So
I don't have an artificial hip.
I think it would be fair to say that over the course of the registry, and particularly in the last 4 or 5 years, we've noticed a steady improvement in outcome. Now, because of the fact that we've got 2.5 million records and there's a huge lag, that's quite slow to develop, but we have seen, we've got some data that suggests that there is a falling off, a dropping in the revision rate overall for hip replacement in the last 4 or 5 years. Part of that is the metal on metal getting out of the system, because we haven't put them in for 10 years now, but actually there's some data that suggests it's not just that, it's about people knowing what the best implants are, selecting them more. There's probably been, well, we know there's been this improvements in surgical technique. The mortality rate for hip replacement, for instance, at the beginning of the register is almost halved. That's got nothing to do with the register, that's to do with improvements in anaesthetic techniques, early mobilisation of patients, reduction in DVT rate, things like that. So we are seeing a steady improvement in outcomes.
Can I ask, the Beyond Compliance programme, to what extent is that a contributor to better outcomes?
I don't think that makes an awful lot of difference personally at the moment, because the numbers are quite small against the whole registry. I think what it's doing is weeding out implants that aren't going to perform very well getting into the system.
Well, that's a good thing.
And that's a thoroughly good thing. The number of implants that arrive and disappear again is very large. I did some work on that some time ago. Roughly 6 new hip implants have been introduced into the system every year for the last 30 or 40 years. That's 6 in. Now of those, most of them just vanish away, but the manufacturers only introduce them if they can persuade people to use them. And we do have this problem I think in all of medicine, of people like things that are shiny and new. I call it Mr. Toad syndrome. Shiny and new, we must have a go. And some people are made that way and will use them because they're like that, and other people say, no, I want to use what's tried and tested. The best implant combination in the National Joint Registry is the for hips, is the Exeter hip. The Exeter hip was first put in 1971, and it remains the best hip replacement overall that we've got. So I've used it my whole career. You know, I sometimes ask myself why anyone would want to use anything else. There are good reasons for that. I'm not saying that's the only good hip replacement, but you do have to wonder sometimes with somebody who comes along with something as a great new idea, and there's a great rush to use it. And metal on metal was a good example of that.
Can I ask you? You've talked a lot about surgeons and clearly their skills, etc. when you discover through your collection of information and that actually you think that one of the manufacturers, one of the products they're producing is actually not as it should be, or it is not as effective as it claimed to be, what is your position then? Do you go back to manufacturers?
So we have two levels, a bit like we do alert and alarm surgery. We have alert and alarm for implants. And at alert level, they just get a letter. It's not as straightforward as it sounds, because we have, for example, an implant that's only used in very difficult circumstances. It's not for use in straightforward knee replacements, say. So if you've got an implant that's only being used for very difficult cases, it may actually be failing at a higher rate, because you're not comparing apples and apples, you're comparing apples and oranges. So we write to them. If it is a level 1 outlier, that is to say it's got a PTIR that is more than twice as bad as the class of implant in which it lies, then a formal letter is sent to the MRHA. Now the MRHA is well aware of level 2 implants, because they sit on the committee that decides what happens, what's a level 1 and what's a level 2 anyway. So they know what's going on, but we do formally communicate them if we get a level 1 outlier.
But in terms of your interactions with the regulators, and in terms of one of the things we're interested in is a lot of the adverse events we have been reported by women, so coming on yellow card on their system. You're saying that you tend to get the professional adverse event reports, but there doesn't seem to be crossover between those two. So is this sort of formal communication for your outliers, is that where the crossover occurs?
Sorry, I'm not. Go on.
No, I don't understand. I'm not quite understanding.
We don't have
we do
not have a system in which patients can tell us about a problem.
No.
But our endpoints are only death and revision.
Yes.
Okay. So we don't have a system that allows us to say, Mrs. Smith has an implant that's not doing very well. We only collect revision data. Now we recognise that is not perfect by any means, but it's a really hard endpoint. It's a really easy.
Are you thinking of moving into PROMS?
We have, PROMS. So PROMS is not run by us,
No.
except for shoulder replacement, where we have our own PROMS system that we do collect. Okay. We would really love to make PROMS work better than it does at the moment.
Yep.
And we would be quite happy, provided we were funded to do it, to run PROMS and run it, I think, personally, on an every single patient basis, which is, it's only very small samples at the moment. And if we were to do that, we would have a lot more information, and we would be able to identify problems much earlier.
Because the national PROMS actually measures at
6 months.
6 months.
6 months.
The 6 month point. Well, for a hip or a knee,
it's not longitudinal enough. We do collect the shoulder replacements. We are collecting our own PROMS, and we're collecting it at pre-operatively, and then I think 6 months, a year, 2 years, and 5 years. So that is the way we think that should happen. And I think if we did that, we'd be able to collect. Yep. We'd be able to identify problems much earlier.
Can I ask a question about sodium valproate? So sodium valproate obviously can cause damage to the fetus and the child. I was wondering whether your system, your registry, is sensitive enough to pick up in utero exposure to a medicine like valproate. Is that something you're able to track, or do track?
It is. So, if an anomaly was detected in the antenatal period, we would highly likely be informed that the woman was epileptic and that she was on sodium valproate if that was the case. So I think we would know if the clinicians were aware. I think what the potential of the system is, once we have high quality data nationally, is that we can link with prescriptions data, and we can do the same thing backwards. So we can look at anyone who is on our register who has also been prescribed sodium valproate whilst they were pregnant, and see.
So you can do a retrospective.
So our section 251 gives us legal basis to collect information on suspected and confirmed congenital anomalies. So that cohort we can link, and the triangulation of the data, I agree, is really important. So again, we use HARES, PAS. We do have access to all primary care prescriptions through the NHS Business Authority. So for known patients, for known cases, if you like, we can go back and use that prescription data, which has got very good coverage, covers about 90% of the population. But we can't do it the other way. So we wouldn't know how many were prescribed sodium valproate who then went on to have a normal.
You've got access to BSA data now?
It's happened in the last 12 months.
Right. Okay.
So that's major congenital anomalies like tube defects, we're much more likely to collect data and be able to link those to sodium valproate. The smaller anomalies like hypospadias that may also be linked with sodium valproate, it's much more difficult for us to make that link because we're much more likely to get that as surgical data postnatally, so baby data. So that's why it would be really useful to be able to go back and link.
Yeah. But also, I'm guessing the neurodevelopmental data you wouldn't pick up because
one of the issues is obviously that happened for women on sodium valproate. Then there's the next generation of anti-epileptic drugs. So the question is whether you're sort of alert to be looking for what the next generation might be delivering in terms of malformations in utero. I'm thinking Keppra and the like. So I don't know whether you particularly then look out for or try to pick up that sort of sensitivity.
I think again we'd have to do that from the prescription data backwards. So we would have to deliberately look at a class of drugs and look backwards to see who is on the database and what the anomalies are around that. Otherwise the danger is that you're looking for anomalies that you think are associated only, whereas if you go backwards you would see other signals potentially.
It's something we want to do much more of.
Yeah,
as I said.
Have you done that?
Yeah, the linkage with NHS BA prescription data has only been more recent. It's actually because we sit within the same division as cancer registration, so they've been doing a lot of work on it, the linkage there. So it's we're looking to explore it further now, but it's relatively new. But I think it has huge opportunity actually.
I'm sure we could go on a lot longer, but I'm afraid we've really come to the end of our time because we've got another group coming in a minute. So I'd like to thank you so much for coming this afternoon and for sharing all your expertise and advice to us. If there are other things you think that we should have questioned you on or you want to tell us, please don't hesitate to come back to us and do that. And just to thank you for what you're doing for women, for the health service, for hip replacements and other orthopaedic replacements. And thank you very much indeed.